Welcome. We are so glad that you have joined us for this big conversation. I am Diane Davies, the chair. The big conversation began 10 years ago when Middleham and St. Peter's Parish recognized a community need for civil discourse on important national issues that affected our community. We addressed such issues as immigration, veterans, and gun violence. 4 years ago, we acknowledged a root problem behind these issues: racism and bias. They became our focus. 22 community organizations have joined in, becoming the big conversation partners in dismantling racism and privilege in Southern Maryland. Our purpose is not to point fingers, but to share our stories, listen deeply for understanding, develop trust, and work together to create a beloved community. Delivering this 8th annual Big Conversation online is due to the efforts of many. In particular, our partner, the Calvert Library, has provided the technology and the talents of our host, Robin Truslow. Thank you, Robin. Thank you also to the small group facilitators from the mediation centers of Calvert, Charles, St. Mary's, and beyond. The annual topic comes from concerns expressed by you, our participants. This is the third big conversation examining racism and bias. The first, titled I Didn't Know, addressed what we didn't know about race and each other. The second addressed inequality in the schools. And today we examine healthcare inequality. COVID-19 has underscored the health disparities and wounds they have caused. Hopefully, COVID-19 will be resolved, but the deep-seated reasons behind the disparities in healthcare will not be resolved unless we name them, understand them, and rectify them. As laypersons and health workers, we have a part to play. It begins by listening to each other's health stories, looking into ourselves, and finding answers for our community. Today's program is in 4 parts: the panel, the facilitated breakout groups, the roundtable where we'll put it all together, and finally, a brief exit survey. The transitions will happen automatically. And now, I turn the program over to our moderator, Loretta Greer, who is a valued member of the Big Conversation Steering Committee. Your program gives more details regarding her very rich, dedicated life to her community. Loretta, would you please introduce the panel?
Thank you, Diane, for that wonderful welcome and introduction. Today, I have the pleasure of moderating our session today, and I'm pleased to introduce our panel of experts. The purpose of today's event is to increase awareness of long-standing systemic problems of bias and racism in healthcare, and to identify opportunities for more equitable delivery of healthcare in our community. There is a Venn diagram in your information packet that will be referred to later in the panel discussion, but it gives you a pictorial view of our purpose for today. Now I am pleased to introduce our panel of experts. Today we have Ms. Cherie C. Wilson, Education and Training Manager for the Johns Hopkins Medicine Office of Diversity, Inclusion, and Health Equity. We have Dr. Lawrence Polsky, who's the Public Health Officer for Calvert County. We have Dr. Nina Brewster, Public Health Officer for St. Mary's County, and Ms. Shanice M. Hudson, Registered Nurse and Director of Quality Assurance, Charlotte Hall Veterans Home. Before the panel gets started, Malcolm Funn, who is a longtime resident of Calvert County, lawyer, community leader, and member of our Big Conversation Steering Committee, will give us historical view of race and health in Southern Maryland. A more extensive bio for each panelist and Malcolm is included in your information packet. Now we'll hear from Malcolm.
Thank you, Loretta. Permit me to take you on a brief journey of African American history. This journey begins in southern Maryland in 1642, when 13 Black slaves arrived in St. Mary's City. Disease, violence, depression increased among the slave population. Death by self-destruction and disease grew at an alarming rate. Female slaves not only helped on the plantation, but were used to replenish the slave workforce through breeding. By 1740, slaves developed immunities to most New World diseases. By 1790, there were over 100,000 slaves in Maryland. In southern Maryland, slaves outnumbered the white settlers. Charles Bell, a slave and resident of Calvert County, describes the life of slaves in his book titled 50 Years in Chains, or The Life of an American Slave. This book is referenced in your program. By 1860, the population of southern Maryland was 42,000, the majority being Black and mostly enslaved. Blacks, still being the majority population, continued to the 1950s. Maryland abolished slavery by a constitutional amendment in 1864. However, Calvert County voted against it by a vote of 634 to 57. At the end of the Civil War, liberation for Blacks in southern Maryland meant no housing, no land, no jobs, no food, no access to health care or doctors. The transition from Reconstruction to the Jim Crow era came quickly and reflected continued extreme repression of the Black population. At the end of the 19th century, there were lynchings in southern Maryland. Blacks had to be self-reliant when it came to health care. There was no hospital in Calvert County until 1919, and Blacks could not use it. There were a few doctors in the county and little cash to pay them. Midwives delivered babies. Home remedies included chimney soot or spider webs to stop bleeding. The marrow of a hog's jawbone was used as a balm for the mumps or measles. Homemade wine for colds and various herbs, most of which can no longer be identified. Segregation was the rule in southern Maryland until the mid-1960s. Schools, housing, transportation, healthcare, entertainment, all aspects of life were segregated. If you're older than 60, you experienced life in that separate and unequal world. When Blacks were allowed to go to the hospital and receive healthcare, the facilities and treatment were segregated. Blacks entered the hospital by way of a separate back entrance and received care in a separate wing. At Calvert Hospital, it was known as the C Wing. A saying among Blacks was, if you went to the hospital, you went to die. From 1927 to the 1960s, Blacks received medical care and treatment from Calvert County health nurse, Miss Myrtle Patton. She served as nurse, midwife, dental technician, assistant, emergency medical technician, and counselor. Now, Nurse Patton's duties as a public health nurse included visits to the homes of African-American ill families. She gave well baby checks to newborns in their homes. She spent hours counseling new mothers, gave various vaccinations to children at home and in the schools. Even today, I can still remember her delivering my younger brother in my parents' bedroom in our home in 1952. There's no African-American alive in Calvert County from 1930 to 1960 that has not been treated by Miss Patton. Calvert Hospital was segregated until 1965. St. Mary's Hospital was segregated until the 1960s as well. The schools desegregated in St. Mary's in the 60s and in Calvert County in 1966. If a bed was not available in the colored wing, the patient was put in the hall. No Black employee could assist a white patient. Interviews with employees working during this period of segregation indicated that we weren't allowed to touch white patients. I was required to clean the delivery room at night. I wasn't even allowed to get a glass of water for a white patient, even if they asked for it. That was just the way it was. Heard one white nurse state, I'm not going to touch no Black baby. There was no recourse to her position, and she was still allowed to continue to work in the hospital. Often Blacks who needed emergency or specialized care would be turned away or go to Baltimore to Johns Hopkins or to Washington, D.C. to Freedman's Hospital for care. Though ambulances were available for whites at one time, they still weren't available for Blacks who had to be transported in funeral directors' hearses. In Calvert County, one white doctor refused to deliver Black babies. In the 1950s in Calvert County, in St. Mary's County, there were no Black doctors, so the Black community came together to raise funds to bring a Black doctor to St. Mary's County. They also established a health savings plan for the Black community. Who cannot forget the Tuskegee study of untreated syphilis in the Negro male? This was a clinical study done in the rural South and conducted between 1932 and 1972 by the United States Public Health Service. I remember a schoolmate of mine suffered a burst appendix in 1950s. Dr. Villarreal insisted on having her admitted, despite the fact that no beds were available in the C wing, even though there were beds available in the White wing. She eventually was placed in the laundry room after her surgery for recovery. To this day, she remembers that she was afraid to drink milk or be around anything white because when she woke up, all she saw was white. In April 1960, I was scheduled for rotator cuff surgery that had to be delayed for a week or so until a bed was available for me in the C wing for my recovery. Southern Maryland until the 1960s was truly segregated in a manner similar to apartheid South Africa, considered apartheid Southern Maryland. Therefore, it's understandable that Black citizens view their health care with suspicion and mistrust because of previous treatment and lack of concern during our journey through life. You can look today at the COVID-19 crisis and see the same thing.
Thank you, Malcolm, for that wonderful historic view of Southern Maryland. At this point, we are going to start with our panel, and our first person on the panel today is Ms. Cherie C. Wilson, Education and Training Manager from Johns Hopkins. Take it away, Cherie.
Great, thank you. So I just wanted to first thank the Big Conversation Steering Committee for the invitation to speak today. So Martin Luther King said that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. In your program, you will see that the Big Conversation Steering Committee put together this Venn diagram, which Ms. Greer referenced at the very beginning, and this shows some of the topics that will be discussed here. I just want to give a little disclaimer that I'm going to give a very high-level overview of some of these topics because entire books and courses have been devoted to them. My topics that I'm going to discuss briefly are what systemic and other factors contribute to health disparities in people of color, what does bias look like in healthcare, and this will dovetail with some of the previous work you've had on unconscious bias, and I'll talk briefly about what can be done to improve delivery of healthcare services for people of color, but it's mostly from the vantage point of inside the healthcare system. So in 2002, the Institute of Medicine published the Unequal Treatment Report. And when we often talk about disparities in healthcare, we talk about it from the vantage point of lack of access to care or from patients who are uninsured. What was unique about this study is that these were all patients who were racial and ethnic minorities who had insurance and who had access to care. And what it did is it looked at health systems, providers, as well as patient factors. But what it did find was that ethnic minorities had less access to preventive care, treatment, and surgery, which resulted in delayed diagnosis as well as advanced disease. And that there was a persistence of race and ethnic disparities in health and healthcare, many of which actually Mr. Fun, who preceded me, actually discussed. So how did we get here? I'm going to talk a little bit about the historical, medical, and scientific context of health disparities. So I'm going to touch a little bit upon eugenics theory, the closure of medical schools, and experimentation, which Mr. Fun alluded to when he talked about the Tuskegee syphilis study. So if we start about testing, medical experimentation, when we look at early obstetrical and gynecologic procedures, these were conducted by Dr. J. Marion Sims, and many people probably have seen this portrait, which talks about a woman who was enslaved, who was being operated on without her consent. Eugenics. This actually came, unfortunately, from Johns Hopkins, where I work, Dr. William Welch. This is basically what created the system of hierarchy of the races. And basically, it considered certain people undesirable, and it led to things such as forced birth control, castration, sterilizations, even euthanasia. And there were whole categories of people who were considered unfit. And then the Flexner Report in 1910, it eliminated basically the majority of medical schools that actually served Black people who wanted to go to medical school, except for Howard Medical School and Meharry Medical College. Later, we had Morehouse College that was founded. What this resulted in which we still see the vestiges of today, is that our healthcare systems, the staff, the doctors, our healthcare professionals, oftentimes do not reflect the communities that they serve. The population definitely doesn't mirror. What this resulted in was African Americans being excluded from medical institutions, and then Blacks being vulnerable to medical abuses and facing barriers receiving medical education. Mr. Fun already referred to the syphilis experiments from Tuskegee, but there were also experiments in Guatemala, and for many, the immortal life of Henrietta Lacks. And again, this leads to mistrust. So when we start talking about COVID-19 and we're talking about developing a vaccine, and why is it that racial and ethnic minorities are not clamoring to participate in these clinical trials? Again, this is definitely because of some concerns and mistrust about the system. So let's move into how those areas worked into decrease in the trust in the medical establishment. We'll talk a little bit about bias towards minority patients. And then there are language and communication barriers as well, which lead to poorer access to care, a poorer quality of care overall, decreased participatory decision-making in patient and provider relationships, as well as lower health literacy. So how do we get here? Well, I'm now going to look at some of the historical social context of health disparities. So what we see are some of our social conditions. Some of what we refer to is social determinants of health, whether it's redlining and predatory lending, which led to residential segregation and housing, things such as inadequate investments in our school systems, and discrimination in access to high-paying jobs, oftentimes positions that don't actually have health care. We also do know that federal housing loans were refused to millions of Black, Hispanic, Jewish, and immigrant families. So many people thought this had gone away, that we had solved many of these issues with the signing of the Civil Rights Act of 1964. And this is a picture depicting this. However, we still have much work to be done. So we talk about structural and institutional racism. From a physical context perspective, we know that we have neighborhoods where there are not enough healthy food stores. There aren't grocery stores. These are food deserts. There are lots of fast food places. Or you might have increased liquor stores, less financial investment. So people don't have access to banks and credit unions, but rather they have check cashing places or payday loans. And so oftentimes this results in decreased neighborhood stability, cleanliness, sidewalks, open space, parks. A study just came out the other day about how there are a lack of parks in largely racial and ethnic minority neighborhoods. And then when we look at COVID, there's increased exposure to COVID due to crowded living conditions, multi-generational housing, mass incarceration. And why is this? Because we have people who are working in roles as essential workers, whether you are someone working in healthcare without proper PPE, someone who is working in public transportation, someone who is on the front lines, our custodians, people who are working in our nursing homes. Basically, people are being exposed disproportionately. Now, what's interesting is when we first heard about COVID-19 exposure, and especially in racial and ethnic minority communities, it seemed as if it was couched in terms of the fact that there were comorbid conditions or chronic health conditions, things like diabetes, heart disease, hypertension, and asthma, almost like a biologically inferior idea that goes back to eugenics. But we need to look at why is there increased stress and blood pressure and obesity and cholesterol and diabetes, blood glucose and lung disease in these communities? Well, this goes back to all the different things that were depicted in the Venn diagram, which are in our program, as well as the things that I am discussing now. Also, we need to look at generational trauma or the field of epigenetics. You might have first heard of this when people were talking about Holocaust survivors and how trauma was passed through generations, and there were studies looking at that. But we've also started looking at this in our indigenous communities as well as in our Black communities and seeing how this basically adversely impacts health outcomes. So what does bias look like in healthcare? So I know in previous programs you talked about unconscious bias in general, but the way we see unconscious racial bias show up in healthcare is that we see that it profoundly affects clinical decision making. So because I'm looking at a certain patient and I'm making assumptions about whether that person has health insurance or whether that person is going to be compliant, I may not offer that person all the treatment options available to them. It also predicts things such as nonverbal behavior. And we know that communication is comprised, about 80% of it is from nonverbal behavior. So things such as eye contact and posture. It also influences the quality of physicians' interpersonal communication with African American patients. We've done studies where we look at the length of a clinical encounter, so time-wise, as well as the number of words spoken. And it appears that there are less instances where people are engaging in small talk, talking about how are things going with the African American patient, because sometimes basically we think that the providers don't feel very comfortable doing so. So there's almost a rush to get that person in and out of the office. And then it adversely impacts impacts patients' trust as well as perceptions of their physicians and their overall healthcare team. So what happens when a patient does not feel that their healthcare team has their best interests at heart and they are prescribed a new medication, or they are told they need to return to get their labs drawn once a week, or they're given a variety of treatment options? When they return and they haven't followed through on what the healthcare team has said, if they return for that follow-up appointment at all, because of this lack of trust, we're quick to label that patient as the non-compliant patient without examining why. We also see racial and ethnic bias showing up in healthcare, again, in the disproportionate burden of COVID-19 pandemic on our racial and ethnic minority communities. If you look at any of the data across the country, even here in Maryland, our Black and Hispanic or Latinx populations are disproportionately burdened in comparison with their population in the state of Maryland. We're also seeing this in our indigenous populations, especially the Navajo Nation, and out west in our Asian and Pacific Island communities as well. From a pain management perspective, think about how those who have sickle cell disease are treated when they come to our institutions. Are they treated with dignity and respect, or are they treated as if they are exhibiting drug-seeking behavior? We've seen studies of children presenting with appendicitis, and if you are a Black child, you receive less pain medicine. And then also too, Black or Hispanic patients who present to the emergency department with long bone fractures are much less likely to receive any pain management of any kind. And then lastly, when we look at the maternal morbidity and mortality crisis and look how it's adversely affecting our Black and Indigenous women, whether we're talking about people like Beyonce or Serena Williams sharing their stories of not being listened to, and how this is leading to the unnecessary death of women in these populations. So what can we do to improve delivery of healthcare services for people of color? And again, this is from an individual perspective within our healthcare systems. So what we want to do is understand who our patients are and their perspectives, treat our patients as individuals, not stereotypes of the groups that they happen to belong to. Understand how powerful unconscious bias is. And also, we need to recognize that when we are rushed, hurried, or it's an emergency situation, we are much quicker to rely upon our biases, and it can adversely impact our patients. We also want to know the class standards, and this is talking about culturally and linguistically appropriate services. So we want to make sure that the services that our healthcare systems are providing are respectful of and responsive to individual cultural health beliefs and practices, preferred languages, health literacy levels, and communication needs, and that we use them at every single point of contact of our organizations. We also want to engage and be knowledgeable and apply the national standards for culturally and linguistically appropriate services in health and healthcare. Lastly, what we want to do is do a teach back or an Institute for Healthcare Improvements Ask Me 3 from a health literacy perspective. If we can help our patients know what is their main problem, what do they need to do, and why is it important for them to do this, we can help basically reduce some of the adverse effects of low health literacy. And then lastly, if we can practice evidence-based medicine, hopefully this will take some of the subjectivity out of this where unconscious bias can come into play. And so with that, I thank you for your time.
Thank you, Ms. Wilson. That was a wonderful overview of very, very important issues that we need to be aware of as we talk about bias and as we talk about inequities and disparities. Next, we will have Lawrence Polsky, who's the Public Health Officer for Calvert County.
Thanks, Loretta.
Dr. Polsky.
Thank you very much. And wonderful presentations from both Malcolm and Cherie. I was given a few questions ahead of time, one of which was specific areas of health concerns, at least in Calvert County, for the African-American population. And I'll start out by saying that as most people who are watching this know, that in Calvert County, we're a predominantly white county with about 14% African-American and a relatively small percentage of other ethnicities, including Hispanic and South Asian, both of which are less than 5% of our population. So the idea of concentrating on African-American in Calvert County is appropriate, although I will mention that as a health department, we certainly take into account the needs of other ethnic or racial groups that have smaller percentages. So in terms of concerns for African-American population, that really spans the entire life cycle. And I was going to say from cradle to well into adulthood, but actually problems start prior to the cradle. We know that for women who are pregnant, that there are higher rates of complications both for the woman herself and in terms of preterm birth for African American women than for the general population. And low birth weight or premature births lead to potentially a host of health complications for children who are growing up. As we get into childhood, in Calvert, the rates of asthma in African American children are about twice as high as the rates of asthma in white children. And then as you get toward older age for congestive heart failure, again, we see about twice the incidence in the African American population as the white population. We also see differences in certain types of cancer, including colon and breast cancer, as well as prostate. So when you take a look at what are the most prevalent types of cancers in the US, those three certainly make the list, and higher rates of problems. So regardless of what you want to take a look at, almost without exception, problems we see in the African American community are greater than in the white community in Calvert, and certainly we can say across the state of Maryland and the US. As Cherie mentioned previously, there are just layers of issues that have developed, really going way back, as Malcolm said, to the founding of Maryland, that have put African Americans at disadvantages and under chronic stress. Cherie made some mention of epigenetic changes. In this forum, we don't have time to get into all the subtleties, but we know that stresses actually affect the way that genes function. So it's not just what you are born with, but the stresses on those genes in terms of being able to create a healthy internal environment. And then we take a look at, I think both Malcolm and Cherie alluded to, that housing oftentimes has been discriminatory in a way that clusters African American residents into certain areas, oftentimes services and basics, everything from access to healthy food to potential for medical care, oftentimes is disadvantaged in parts of counties that have higher concentrations or higher percentages of Black residents. And then we get into once somebody feels ill or considers doing preventive care, and how welcome do they feel within the medical infrastructure. And again, both the previous speakers mentioned how African Americans have been in many ways stigmatized or even overtly discriminated against as they've tried in the past to get care. And there are, I think, lingering problems as children grow up in an environment where their parents, grandparents have a distrust of the medical community. So as they grow up, how are they going to seek care and from whom? So there's just a tremendous amount to be done, and certainly in the very limited amount of time that we have in this discussion, to try to get into a really deep discussion and come up with all the different types of approaches we need to take to make things better is kind of beyond, but hopefully for most people listening, this is the start of a greater realization of things that they can do as individuals. So I will just mention one important factor is that for people in the African American community, they certainly should take advantage of the healthcare that we do have in the communities. And when they see their providers, it should be a true discussion between both patient and healthcare provider. And that goes on both ends of that equation. So as a physician, all the nurses that I work with, for all of us as healthcare professionals, we need to reach out to our patients, and regardless of background. I am not Black. I will never be Black. I can't understand truly at a core what it's like to be a Black person in the United States, but that should not and hopefully has never stopped me as a physician to reach out to my patients and try to understand from their perspective what sorts of issues we need to bridge, what type of information they need to hear from me in order to make better decisions for their health, and what sorts of concerns that they have, so that we can work together to come up with a plan both to properly diagnose and then to move ahead with treatment. So again, I would encourage both people out there who need healthcare and then also for healthcare providers that both have a role to play in moving forward to make things better. As a health department, we work with healthcare providers. We're particularly concerned during this era of COVID, having seen the disproportionate percentage of deaths in the African American community, to number one, make sure that people who need care get the care that they deserve and in a timely fashion. But also, as we continue what will almost certainly be many more months dealing with this virus, that we know that African Americans oftentimes have higher rates, or not often, but as a community have higher rates of both diabetes and hypertension, and that the better their underlying health conditions are treated and controlled, that if for each a given individual they do develop or they do contract coronavirus, that they will be less susceptible to the most severe consequences. We certainly don't want to see anyone end up in an intensive care unit, and certainly to the point where their life would be in jeopardy. So we have been, as a health department, reaching out to all of the primary care practices in our community, asking them to go through their electronic health records and reach out. Don't wait passively, but reach out to patients in the African American community who they know have diabetes, who they know have hypertension, but perhaps it's been 6 months or more since they've had an appointment, to try to actively get people engaged in care, better control of their underlying health conditions, so that again, if for those individuals they should contract COVID, that they'll be less at risk. And I will close out, because I know I'm getting close to my 10 minutes, by saying that also, as part of that distrust that has developed over generations, is a significant lower rate of immunization, particularly for flu vaccine in the African American community. African Americans are on the whole 25% less likely to get vaccinated against the flu than white people. And we know that for some people last fall and winter, they had both influenza and COVID at the same time, placing them at much, much higher risk of serious complications. So the other outreach that we've been doing is to encourage in the African American community, if people have not been vaccinated in the flu in previous years, to consider for this flu season to get vaccinated, and to get vaccinated either in late September or very early October. So I will close with that, and I will be available for questions later. Thank you very much.
All right, thank you, Dr. Polsky. We do appreciate the point that you gave us in terms of working with our residents and constituents in Calvert County. At this point now, we'll hear from Dr. Mina Brewster.
What I'm going to be talking about today during my portion of the panel is really introducing the topic of health equity in general and what that is, and then also what is public health's role as it pertains to health equity, and what is the St. Mary's County Health Department doing in particular on the topic of health equity. So what I'll do first is share my screen so you can see I did make a few slides. So really, when there is health equity, we see that as a place where everyone has the opportunity to attain their own individual highest level of health. And when there is health equity in a community, all people benefit within that community. Communities are better and stronger because there is health equity. You see a lower burden of disease and death. There's lower healthcare costs for the whole community. The population overall in that community is happier because we're better in all sectors that rely upon good health. So sectors like the economy and employment, education, safety, and certainly housing as well. All those sectors of community rely upon people being healthy. And the healthier that population is, the better success we see in those other sectors as well. And so that is why it's so important for a community to advance and ensure that it's working towards a space of health equity. Healthcare services is a part of health equity, but it is not the only thing within health equity. Health equity is about the total concept of health. And while healthcare services and healthcare access is an important aspect of that, our concept of health, our context of health really goes beyond just the healthcare delivery system. You may have heard the words health disparity and health inequity, and here I'm trying to identify what those are and what those how they're different. So health disparity is really just a difference in an outcome. So either you have worse death or worse illness or worse risk factor, whatever it might be, in a certain group compared to another group. It's just a difference in an outcome in one group of people compared to another. A health inequity is when that difference in health outcome, that disparity, is considered to be preventable or is unfair or unjust. So for one example of a health disparity is that in general, male babies overall may be born at a heavier birth weight than female babies. That's a difference in outcome between males and females in their generally as an average on the population level as a birth weight. But health inequity is something that Dr. Polsky had actually referenced recently in talking about the challenges that African-American women face during their pregnancies and beyond as well. And so babies born to Black women have a higher likelihood or higher risk of poor health outcomes or even death in their first year of life compared to babies born to white women. And so that would be considered a health and inequity, that the reason for that outcome difference are probably, those reasons are probably preventable and may be tied to unfair reasons or injustice. Getting to health equity involves knowing what disparities we're working with and which of those disparities are actually preventable or are actually inequities. And so once we as a community work to look at the data and research what's going on in our community and get a better sense of what's happening in the community, then we know what those disparities are, and then we can work to identify what their root causes are. We examine, what are the reasons why these disparities are happening, what's contributing to them, and what might actually be protecting us from disparities, and how can we enhance the protective factors and mitigate or decrease the risk factors and overcome all those barriers. Once we're able to identify all of that, then we can actually implement a variety of strategies as a community to address them. And primarily when we look at addressing health equity and we look for sustainable change that is not reliant upon a grant program or something that might have short-term funding, we really start talking about how do we change policy in the, whether it's public policy or organizational policy to promote equity. How do we change the systems around us, whether those are institutions like the healthcare system or others, and what kind of changes can we make in those systems so that they better promote equity in health? And then how can we change our environment? Perhaps this is tied to air quality or water quality, and are certain communities more at risk for worse air quality or worse water quality and so forth, and how does that impact health if they are? And then also developing targeted programs where they're needed, specifically to address some certain risk factors or certain communities in particular that may be struggling on certain topics. All of this is complemented by continuous education with our community, communicating with our whole community about what health equity is and why our work in achieving health equity is important, and promoting the partnerships that we need on the ground at the local level to leverage those public and private resources and get things done. While we're doing this, it's important to pay attention to marginalized groups, particularly groups that have faced historical injustices and disadvantages from a social or economic perspective. And so this is where we start paying more attention, in particular to certain racial ethnic groups like our African American population, Latinx population, and others who may have experienced more challenges as they've may have been marginalized within the community over years. This graph here I just liked because it illustrates some of the partners that we in health and public health work with quite a bit, because when we're talking about health equity, we have to consider the effects that health experiences from all these different sectors in a community, and then also how health affects all these different sectors of a community. And that's why these partnerships with these different sectors and many others that aren't pictured here, but these sectors for sure are so critical as communities work towards a place of health equity. So now I'll talk about public health and really what is public health and why are we talking about health equity? Really public health is based in science. I mean, everything we do in public health is based in science, it's data driven, but it is the action of protecting and promoting whole populations and the health of those populations and our communities. So here at the St. Mary's County Health Department, of course, our population of concern is St. Mary's County. And so our whole population or community that we're concerned with at our public health department is all the people who live in St. Mary's County. So health equity, based on this, really, as you can see, health equity is really at the core of what public health does. We can't successfully address the health of our whole population if there are parts of our population that are being neglected or that are seeing significantly worse outcomes than other parts of our population. As you can see, this is what we call the kind of the core of public health, the wheel of public health, the essential services of public health. And if you read through this or just kind of identify some of the functions, the essential services of public health really align so well with the work I was describing earlier as to what we need to do to address health equity. So from monitoring the data or the disparities to investigating them to figure out what the root causes are or what are the policies and structures and systems that are contributing to health inequity, to mobilizing our partnerships and developing policies and changing systems and how we do things. And throughout it all, making sure that we're evaluating everything that we're doing to make sure it's having an impact, that we are constantly looking at all those different factors and finding new ways to address those different factors based on the science and the data that we have. As you can see, again, our work in public health is founded upon the principles of health equity, and our approach towards health issues and community health overall is very much reflected in how communities can successfully work towards health equity. Here in St. Mary's County, our St. Mary's County Health Department has really, we take it very, very seriously, this foundational role that we have in providing input and leadership and partnership to our community and working towards health equity. Recently, here in St. Mary's County, the health department partnered with the St. Mary's County Public School System and the Sheriff's Office to establish a joint equity task force here in our county because we recognized the interplay of education, public safety, and health, and that being able to achieve equity in health relies upon being also able to achieve and work towards equity in education and in public safety. And so because of those strong linkages across these three sectors of community, and because of the strong partnership that our agencies have already established, we stepped forward with this task force, and we're really excited. This happened fairly recently in the past handful of months, and we're really excited about what's on deck for our community. We have several collaborative initiatives in development that we'll be announcing as they're ready. And We're very eager to engage many partners throughout our community and stakeholders in gathering input and working towards a variety of ways that our community can work together on achieving equity in all those sectors of education, public safety, and health. But certainly, for the purpose of this topic, of course, the health department, we're very keen on the health equity aspect as well. As a health department, we did publish a health equity report in 2019, and you can identify that on our website. The address is there. The health equity report really goes into and identifies certain health disparities that are experienced here in our St. Mary's County population based upon the data that we had available at that point in time. And then also kind of cross-analyzes what other factors in a community, including housing, might be affecting health of different groups or populations within our community. That was a short report. We're actually working on building out a much more comprehensive analysis of health disparities and health inequities and the factors that contribute to them. We are working on developing a report. It might actually be a dashboard kind of format that we make available to our community. We also recently hired a health equity coordinator, one to, of course, help us address some of the disparities that we're seeing with COVID-19, in particular, as was referenced earlier by the panel. But also overall to help us as a health department evaluate everything we're doing in terms of our public health programming and initiatives to ensure that we're making concentrated effort to address health disparities across different health topics and really work in a coordinated way across different programs that we have here in public health towards health equity and to help us engage our community partners around this topic of health equity as well. All of our ongoing work in public health, so much of it is geared towards achieving health equity within our community. And we're excited because, coming up in the near months, we'll be rolling out a series of learning opportunities for our community around the topic of health equity. We employ and we're looking to build more of a community health worker workforce. And the concept of community health workers is really people from the community who are laypersons, but are trusted advisors within their communities, maybe have shared lived experience with that community, and so therefore are in a place and position of trust. If they can be engaged as a health advisor or community health worker, as we call them, then we may have much more success in reaching many individuals in our community and better engaging them as they make decisions about their health. We also work very closely with all of our elected officials and organizational leaders to help provide input as they develop policy and hopefully to implement policy that works towards health equity in our community.
Thank you, Dr. Brewster. That was a very excellent presentation. You did cover several interesting points in terms of involving the community in health equity, and we find it to be very important. Next, we will hear from Ms. Shelnice Hudson. Thank you, Dr. Brewster.
Good afternoon. Thank you for inviting me to be a panelist today. When we discussed inequity in healthcare, it is indeed a big conversation. It has its roots in the foundation of our country. So we have to examine our history. And I'm so glad that Ms. Wilson and Mr. Fun went over some of those points with us. When we look at like the gynecological surgeries of Dr. James Sims, well-documented cases performed on enslaved women, he performed those cases without any informed consent, without anesthesia. He promoted the ideals that are still prevalent today, that Blacks don't feel pain in the same manner as other ethnic backgrounds, and we have to, examine that. And that shows up in our daily practice, as Ms. Sherry kind of touched on. When we look at our patients of color that come in with sickle cell anemia or other elements to the hospital, and they're just kind of labeled as frequent flyers or pain seeking, and we're not really dealing with the medical issues that they have that are extremely painful. When we jump forward to 1807, after the British slave trade ended and the price of slaves increased, we look at how slave owners felt that it was more beneficial to treat slaves medically, and we see slave hospitals opening up in all of these slave ports like Augusta, New Orleans, Charleston. Those slaves virtually became the property of those physicians until their owners could pay off what they were originally owned. So tremendous treatments and surgeries happen, again, without the consent, without the pain medication. And these distrusts are still relevant today, and they're still felt today. When we're looking at like the Tuskegee experiments of 1932, 399 men were in the study. 198 of them were positive for syphilis. These men were never told what their exact ailments were. They were told that the study was going to only last for 6 months. Even when a cure became available in 1947, they weren't offered this cure. We had 40 wives that were infected, 19 children that were born with congenital syphilis. So, I mean, we can see why these problems are prevalent today based on our history. And when we discuss implicit bias, those unconscious stereotypes that we attribute to one another versus the explicit bias, those conscious stereotypes that we foster, those bias include such beliefs that African Americans are loud, emotional, lazy, uneducated, or unmotivated, and violent. And you have to think about, you know, what's promoting this. I honestly think that we're in a time of history where there's a blending of implicit and explicit bias. And it's the blessing and curse of living in a digital age, blessing and curse of social media and streaming videos and news. The average person's inundated with these images constantly. And the implicit bias that I've witnessed in my career are providers suggesting that other providers aren't as talented or educated as they are. One example that I can think of in particular is a Black female hospitalist went to see a patient, and that patient was having a heart attack. She asked the emergency department physician to send information to our sister hospital that had the cardiac intervention unit. The emergency department physician, all she wanted was for him to like transmit the EKG remotely to the sister facility. He decided that she was not capable of taking care of this patient, and then began to criticize her and insult her in front of other staff, saying that she didn't have the knowledge or the expertise to properly take care of the patient, when in fact, the only thing that she needed to know was how to transmit the EKG. Examples of explicit bias that I witnessed as a newer nurse were at a time that I was hired. There were only 3 African-American bedside nurses in this facility. The facility has 3 floors, so there was 1 African-American nurse on each floor. When I got to the elevator, there was a housekeeper on the elevator. She questioned me after kind of looking me up and down, wanted to know, you know, why was I wearing the color scrubs that I was wearing? Only nurses wear that color scrub. Well, I explained to her, well, I'm a nurse. And then she kind of looked at me, questioning, you know, confused. And then she asked me if I attended school. No, well, yes, I went to school. After that, she was like, oh, okay, well, we got to the 2nd floor. It's a med-surg floor. Oh, aren't you getting off the elevator? No. Well, you work on the 3rd floor? Yes. well, where do you work? Tele? No. Oh, you're an ICU nurse, like very surprised, like mouth fell open. It's like, yes, I'm an ICU nurse, and kind of stepped off the elevator and left her there. But I mean, those are examples of the kind of things that we deal with as an African American healthcare provider in St. Mary's County is where I reside. So we have to look at those biases that we're projecting, that we're subjugated to on a day-to-day basis. Other examples that I have witnessed and that I've noticed are when we have African American or managers, supervisors of color, how their critiques are entertained, or how their critiques are received by employees. It's very challenging. It's very difficult. You're seen as being challenging or being difficult, and the same critique could come from one of our white colleagues, and it's just seen as that, just a critique and something that needs to be addressed by the employee instead of then the supervisor. How dare she, how dare he have the nerve to say that to me? So these are the waters that we're navigating through as persons of color working in the healthcare community in its current environment now. Other healthcare disparities that I think that are worth mentioning are the access to quality care and the lack of clinical trials and studies and documented research for people of color because of the distrust that's happened in the past. But I want to be clear that these healthcare disparities aren't just noted in people of color, but we have to look at race and gender and sexual orientation. Patients, not all patients are just white heterosexual males, and research and education has to encompass the full spectrum of the diversity that is the human race. One recently highlighted issue that has been like the COVID rash and the COVID toe. I'm sure that we've all seen this information. There have been so many publications and photos of white patients with COVID rash and very few of persons of color. So there have been suggestions that we're not able to, or the healthcare community is not able to recognize these early signs in COVID patients because that documentation's not out there. Those publications aren't out there. So providers don't know how to recognize these skin conditions. Other healthcare disparities that we've highlighted during COVID-19, I mean, they've just truly been shocking, where healthcare workers of color are twice as likely to succumb to the ravages of COVID-19. Blacks have a significant infection rate and mortality rate than that of whites. And again, I mean, these are things that are all documented, that they're collecting research on and publishing every day. Other examples that I think that are interesting that we're still dealing with decades past are like just ACE inhibitors and how we treat high blood pressure, and how the education isn't given, and how African Americans that are on these drugs don't realize that, hey, these drugs can affect, the way that they can affect you, the allergic reactions that can occur. So when we look at like the COVID color lines, and the information that's out there, and we know that this is a problem in the healthcare industry. I mean, it's up to us to have these conversations. It's up to us to do the research and to be open-minded and to see how these events affect not only us personally, but our coworkers, our neighbors, our friends, our families, the community at large. We can go on and we can discuss environmental factors, pollution and socioeconomic gaps people of color face within their own community. I was on a panel discussion about a month ago, and they discussed the 301 corridor and how it's one of the heaviest polluted corridors in the state of Maryland. And I mean, and it's heavily populated by African Americans. I think Dr. Polsky stepped on the topic of pollution and how it relates to health disparities and persons of color. So we know that these workers are more productive. We know that workers are more productive when they're teleworking. So, I mean, this is the perfect opportunity to kind of knock down some of these barriers that we're seeing. So vulnerable communities have better opportunities, and also reducing, of course, the carbon footprint. And let's face it, the role that bias and racism has is to divide us and to feed on fears, the fears of loss of jobs, opportunity, safety, security. In other words, keeping working class people from organizing and challenging political and governmental structures. But it's all rooted in colonialism. It's all rooted in racism, and it ties back to slavery. So, I mean, it's just time that we tear down those barriers, that we start communicating. And that's why this platform is so important. And I think one of the easiest ways to date to break down these stereotypes is to have diversity in all levels of management. A lot of times in organizations, we see that middle management, where African Americans or persons of color are able to break through to middle management. But then when we're looking at upper levels of management, there's not adequate representation. So developing and including equity coordinators in our organization, those are tools that we can use to combat this racial divide. I thank you. That's all that I have for you.
Thank you. Thank you, Ms. Hudson. That was very informative. We've had a very, very interesting conversation today, and I think the panelists have done an excellent job covering the entire spectrum of what inequities, what it means to have inequities, and what disparities are in terms of Southern Maryland race and health.